everybody, welcome back. For those of you who are watching for the first time, welcome. I'm Dr. Kresh from Columbia University, and today we are going to talk about how not to miss pigment dispersion syndrome. So we're going to break this down into 4 sections. The first is your slit lamp exam. The second is intraocular pressure. The third is gonioscopy, and the fourth is your fundus exam. For your slit lamp exam, you're basically looking for pigmentation, and this can be manifest in different ways in different patients who have pigmentary dispersion syndrome. The first area that you have to look is the iris itself. What are you looking for? Transillumination defects at the mid-peripheral portion. And the way to see them is you get your beam in a parallel pipette, bring it to a 90-degree angle, shrink it down to a conical beam, direct that light into the pupil itself, and you're going to look 360 degrees around the iris for slit-like defects anywhere in the peripheral portion. They don't have to be in the same location day to day, and they don't always have to be present in order to make this diagnosis. The second thing that you're looking at is the cornea. The corneal endothelium tends to have Krukenberg's spindle, even though it's not pathognomonic for pigmentary dispersion syndrome, because you can also get that appearance of pigment on the corneal endothelium from conditions like exfoliation syndrome. It's still an important finding, and it's important to document when it's there. So you're getting this Krukenberg spindle, which is basically pigment deposition that arises from the sloughing off of pigment from the posterior iris, which gets caught up in the convection currents, comes into the anterior chamber, and lands on the corneal endothelium and goes through phagocytosis from the corneal endothelium. It lands in a spindle pattern, which means that it lands more heavily at the base and it's more narrow at the apex. The other thing that you want to look at with the slit lamp is your lens. After you dilate the patient, sometimes you can see pigment granules on the lens itself, typically around the equator portion. All right, second section, IOP measurement. So pigmentary dispersion syndrome patients can have a very wide fluctuation of IOP, intraocular pressure. And what I mean by that is a patient can come in one day and have a pressure of 10, come in the next day, have a pressure of 30. It's a good idea to measure IOP initially and then after dilation, because sometimes you'll pick up a spike after the patient dilates. And these patients can spike up to 50 or 60 millimeters of mercury. The third section is gonioscopy. You're looking for a few basic things in gonioscopy. The first is a concave approach to that iris. This is pretty pathognomonic for pigmentary dispersion syndrome because that concave approach of the iris is the reason why there's that mechanical contact between the iris and the lens zonules, which causes that pigment to be liberated in the first place. So the best place to see this is on gonioscopy. If you put the 4 mirror or the 3 mirror on the iris, you should see a wide open angle that's kind of concave. And it can be pretty dramatic if you're looking out for it. It can also be subtle. So always be thinking about the approach of the iris when you're doing gonioscopy. The other thing that you want to look at is the pigmentation of the trabecular meshwork. In pigmentary dispersion syndrome, the pigment tends to be very dense and uniform throughout the trabecular meshwork. You can also get a speckling of pigment at or anterior to Schwalbe's line called a Sampolesi's line. You can see this in different kinds of glaucoma, including exfoliation syndrome, but again, it's important to find it and document it in pigmentary dispersion syndrome. Okay, after you do your gonioscopy, you're going to dilate that patient. 2 things to be aware of. First of all, obviously, pigmentary dispersion syndrome is a secondary cause of glaucoma, so you want to pay close attention to the optic nerve and probably run some imaging. We're not going to go through imaging in this video. The other thing that you have to be aware of is that pigmentary dispersion syndrome has a tendency to be associated with retinal breaks and lattice degeneration. So always dilate these patients at least once a year if they're asymptomatic, and if they're symptomatic of some kind of retinal disturbance, then you want to be sure that you're looking carefully at the fundus and making the appropriate referral as necessary. So a quick review of pigmentary dispersion syndrome: you're looking at your slit lamp for transillumination defects, Krukenberg spindle, lens pigmentation. You're doing IOP measurement, monitoring for spikes. You're doing gonioscopy, looking for a concave approach and a densely pigmented trabecular meshwork, sometimes with a Sampolesi's line. And in your dilation, you're looking at the nerve itself for glaucomatous changes, as well as retinal breaks and lattice degeneration. Thanks for watching.